Good morning, everyone. Welcome to Carilion Clinic's Pediatric Grand Rounds today. Today, our speaker is Dr. Benjamin Lovin. He's a double board certified in otolaryngology, head and neck surgery, and neurology. He completed his residency in otolaryngology, head and neck surgery at the Baylor College of Medicine. Following residency, he completed fellowship in otology, neurology, and lateral skull-base surgery at Baylor College of Medicine at MD Anderson Cancer Center. He is currently an assistant professor in the Department of Otolaryngology, Head and Neck Surgery at the University of Virginia. His clinical interests include implantable hearing device outcomes, quality of life in chronic ear disease, and lateral skull-base surgeries. Please join me in welcoming Dr. Ben Lovin.
Good morning, everybody. It's great to be here. Thank you for the invitation. It's really an honor to come out here to be able to speak with you guys here in person and online here, just to talk about a few things that I'm pretty passionate about. And it's been great over the years to also have this nice collaboration between the pediatricians and otolaryngologists here in this area that take care of these complex kids. So we'll talk about a lot today. It'll be a little bit of a whirlwind, and I'll try to get through it in kind of a timely fashion. But really, we're going to be focusing on the importance of diagnosing pediatric hearing loss, how we do that exactly, the workup, classification, and then ultimately how we manage some of these kids, but ultimately talking about some different aspects of cochlear implantation. And so kind of another title for this talk, which I like, is kind of the who, what, when, where, why, and how of cochlear implants. Nothing to disclose, and here are our objectives, really kind of talking about really how we confirm, diagnose, classify hearing loss, how we ultimately work up and manage these kids, and then ultimately how we treat them, right? What are the important cochlear implant considerations, and then how do these kids do after surgery, and how do we expect them to perform with the cochlear implants? And so let's look at a kind of a generalized timeline for a child with hearing loss. And so all patients will really go through this kind of to some varying degree if they ultimately have hearing loss and undergo a cochlear implant at some point in the future. And so we'll really use this outline as kind of a framework for our discussion and talk here today. But briefly, within this timeline, what are kind of the time points granularly that we're shooting for? So, of course, the CDC and the EHDI, the Early Hearing and Detection Intervention Group, have really outlined this 1-3-6 benchmark first, where screening should be done by 1 month, confirmation of hearing loss by 3 months of age, and then ultimately starting support services amplification by around 6 months of age. And so let's first look at how we start accomplishing this in the postpartum period with postpartum screening. So, of course, when we're talking about children, this will start at birth, and so from a hearing perspective, this of course starts with a newborn hearing screen. But how exactly is this done? So this broadly can take two different forms of a hearing screen, either an OAE or an otoacoustic emission, or an AABR, which is an automated auditory brainstem response. And so broadly, OAE here on the left really tests the ear's response to sound, whereas an AABR tests the brain's response to sound. So OAE assesses the response of sound created actually by the cochlea in response to an external sound. And so if we play sound from a microphone into the ear, we're actually able to record some sound back. So a little bit counterintuitive from what we're thinking from really a receptive organ. And this is what an OAE is. And as such, it really tests the external ear, the ear canal, the middle ear, and then the inner ear portion. But on the contrary, an automated ABR is essentially what I like to think about is like an ear EEG in its simplest form, where we are recording brain waves after an external stimuli, such as sound, is played. And as such, this automated ABR test really tests the entire auditory pathway that you can see here, which really makes it a little bit more robust than an OAE, but it's a little bit more time-consuming to perform as well. But because these are testing two different pathways entirely, it's really important to know that there can be some inconsistencies between the results here. So some kids who may pass an OAE ultimately may fail an automated ABR and vice versa. And so this chart down here at the bottom kind of reflects some common instances in which we'll see this conflicting results. And what you can see here is that generally in those cases where there's an OAE failure, these are often from temporary issues after birth, such as fluid in the middle ear or ear canal infection, whereas those from an automated ABR failure generally reflect more permanent issues that generally need long-term follow-up as opposed to temporary issues from an OAE failure. And so at UVA a few years ago, we switched from OAE to automated ABR, and ultimately this has kind of led to a lower number of referred patients to audiology in the future, just given these temporary issues that ultimately resolve in a short time frame. And so demonstrating this difference in kind of ultimate referral rates after these two different types of tests, a recent study evaluated over 2,000 newborns who underwent both OAE and automated ABR at 3 different time periods after birth. You can see in the top part of this figure here, 24, 48, and 72 hours after birth. And not only did they find a decreasing failure rate for both as time after birth increased, likely accounting for these temporary ear canal and middle ear issues as we discussed, but also they found a lower false positive rate for the automated ABR than OAE. And finally here, this figure on the right just demonstrates what we already know. The automated ABR does in fact take longer, of course, than OAE, but probably this upfront investment in time from the audiologist after birth with an automated ABR is ultimately realizing kind of less diagnostic tests needing to be performed at a future date from the audiologist. But ultimately, no matter which one of these tests is done, we're really just here to try to identify these kids who have hearing loss or may be at risk for hearing loss with these screening tools. But even though, unfortunately, we're really jumping through all these hoops, really just to try to identify these kids, we're not perfect at screening these kids. So this is data a little bit old now, it's in 2022, but really showing that some newborns are sneaking through the cracks and ultimately lost to follow-up. And so thankfully, Thankfully, though, in Virginia, we're doing slightly better than national average, which you can see here, we're about 18% failed newborns lost to follow-up as opposed to about a third of kids nationwide. So now we kind of understand, what happens immediately after birth, but when that happens after that, after we get a positive or a failed result. And so if they pass and we have no known risk factors for progressive hearing loss with time, the child ultimately receives one of these cards and screenings, which I'm sure many of you all have seen, and ultimately they'll just get kind of routine screenings throughout childhood in the pediatrician's office as needed based on their symptoms or any concerns. But alternatively, if they pass, but they actually have risk factors that we know about for progressive hearing loss, follow-up testing will, of course, depend on the exact risk factor and number of them, of which I've listed out a few here. And when I kind of think about these different risk factors, I generally always will come back to this flow chart and this table here I'll show in a second to really kind of get into the granular detail of when they should be followed up. And so this great flow charts from Bowers et al. From Pediatrics a few years ago, and you can see here that even if the screening is negative and there are still risk factors for delayed hearing loss, of course they still need audiology follow-up at some point in the future. And to determine exactly when, this is a big table here, but this is one I like to refer to. It's from the JCIH, or the Joint Commission on Infant Hearing from 2019, and it's kind of their position statement on risk factors and when there should be ultimate follow-up from a hearing perspective for these children. And so the main takeaway here is that if there are risk factors, there really should be some repeat testing, generally done before their first birthday, depending on exactly what's going on. But alternatively now, the newborn actually failed their newborn hearing screen, forced follow-up diagnostic testing is really needed as soon as possible so we can fully understand what's going on. And we'll talk about exactly how to do this momentarily, but before we get into the weeds of that, what else actually needs to happen now that we have a failed hearing test? So as many of y'all know, in September of 2020, Virginia state guidelines completely changed such that Virginia became a targeted CMV state, which means that when any infant fails a newborn hearing screen, a reflexive CMV test should be ordered and performed for 21 days of life. And this was passed as CMV is the most common cause of acquired pediatric hearing loss. And the hearing loss from CMV, as you all know, can really be highly variable. It can be 1 year, it can be 2 years, it can be sudden, progressive, it can be mild, profound, or either early onset or delayed hearing loss. And really this range is pretty significant. And CMV testing, of course, is not only important as it gives us the reason why kids may have hearing loss, but also provides possible treatment, allows investigation of other sequelae from the disease process, and ultimately provide expectations for possible delayed onset hearing loss as well. And so pertaining to this kind of last thing that we were talking about, where there's this progressive ongoing delayed hearing loss in some of these children, this graphic here on the right is from a landmark paper which really demonstrated a significant difference in rates of delayed onset hearing loss in those kids who actually have early onset congenital hearing loss versus those who do not, within all CMV patients. Ultimately telling us if there are kids that have early onset hearing loss, there's a significant rate of developing ongoing and progressive hearing loss in those kids compared to those who actually do well right after birth. And in symptomatic cases, the proportion of hearing loss across the board is generally about 3 times higher. And so this table down here is from Gideris et al., also for Pediatrics, and you can see here within the symptomatic CMV cohort, this is generally about 30% as opposed to about 10% in the asymptomatic cohort. And so now the final point here is that, of course, it's really important for us to distinguish between a postnatal acquired CMV infection or a congenital CMV infection. And so really obtaining this testing within the first 21 days of life to be able to really understand that difference is really important because it really determines effectively the risk factor for either presence of hearing loss and ultimate progression of hearing loss as well. And so, of course, if testing is positive, there is treatment, and I don't want to dig in too deep here. It's not the kind of the point of the talk here, but let's suffice it to say that for both symptomatic and asymptomatic cases, treatment with antivirals works well, right? So this top figure here is from Pasternak et al., who evaluated asymptomatic CMV patients and noted that about 70% of patients had hearing improvement, and this was actually better the more mild the hearing loss was. And now, back here, alternatively, this bottom figure now is from a New England Journal of Medicine article evaluating symptomatic CMV cases, so different from the top figure, which look at asymptomatic, and again, noted better hearing outcomes for those with treatment, and specifically for those with a longer-term treatment where they compared 6 months versus 6 weeks of valganciclovir. And for those with the longest follow-up at 2 years after treatment, which I've kind of highlighted here in this red box in the bottom right, about 77% or almost 80% had improved or stable hearing after 6 months of treatment. And the stability of hearing within these first few years of life, within this perilingual period, is incredibly important, as we'll discuss a little bit more later on. So now that we've kind of gotten that in our back pocket, and now let's start working on talking about confirmation and diagnosis of hearing loss. And again, our goal here is really for this to be around 3 months of life that we know that there is hearing loss. So how are these kids formally diagnosed when they come back for follow-up? Our goal at the end of the day is to get ear-specific and frequency-specific data on hearing loss, and truly the gold standard test for this is a diagnostic ABR. So this is, again, very similar to that automated ABR we talked about earlier, but in this case, we actually are trying to do a true threshold search across multiple frequencies and, of course, for each ear. And again, this is really just an ear EEG, where we are getting these waveforms here in response to presenting an auditory signal, and we generally get these 5 waves in response, really correlating to different stops along the central nervous system auditory pathway. The presence, latency, and amplitude really of each one of these waves, but particularly the near the end, wave 5, which is the largest and most robust wave for us to measure, really determine if we can classify it as a true response or not to that particular sound. But how do we go from all these, squiggly waves, right, that are hard to interpret to an audiogram on the right, which we're, of course, more used to seeing? Simply, we just need to repeat the ABR at different intensities, different frequencies, and of course for each ear to be able to plot this graph on the right. So for example, you can see here on the left from an ABR, we are able to find a wave 5 kind of categorized by that red box and then the wave 5 marker there at around 60 decibels, and this was the lowest intensity we were able to find it for that ear. And so effectively just go over and plot that for the ear and the frequency and the intensity on the audiogram, and then we just repeat that across multiple different frequencies and of course for each ear. And we can either do this in the office while the baby is asleep or in the OR under sedation. And because you imagine it can take a while to actually perform this test, patient age is really critical in knowing exactly how they're going to tolerate each one of those. And so generally around 6 months is kind of that cutoff for being able to do it in the clinic versus in the operating room. Generally, if they're younger, they'll be able to sleep a little bit longer, and we can do that testing in audiology. Anything after 6 months, generally, we might have to go to the operating room and do these under sedation to be able to get a full and complete hearing test. And so now the final part of the ABR is really that this test, of course, needs to be done now within both ear conduction and bone conduction to be able to test the different hearing pathways. So ear conduction, just as a review, is like wearing an ear pod. It's right, wearing a headphone, and these are where the sound waves are, of course, going through your ear canal to your eardrum, going through your hearing bones, ultimately to your cochlea. Whereas alternatively, bone conduction, excuse me, it's like wearing those kind of original Aftershocks headphones. Not sure if anybody actually have those or not, but they physically vibrate the mastoid bone behind the ear. And so they were completely bypassing the ear canal, the middle ear, and going straight to the cochlea to produce the auditory signal. And this entirely bypasses all of that, and so it's not dependent on the presence of any of those structures and really independently assesses the function of the cochlea and the cochlear nerve. And ultimately, understanding how both of these are functioning gives us an idea if we can classify the hearing loss as conductive or sensory neural. And if there's a discrepancy between these two, then it must mean that there's a conductive hearing loss, which of course is an issue with the mechanical transduction of the sound, as we said. And alternatively, if there's really no discrepancy between the two, then we're really dealing with a sensory neural hearing loss, and the issue is either at the level of the cochlea or the cochlear nerve, because that's kind of the common unifying pathway between these two types of sound conduction. And then, of course, really this dissection is ultimately critical because it not only depends how we investigate the hearing loss, but ultimately what rehabilitative means we can use for hearing loss as well. And so examples of sensory neural hearing loss may be things that are overtly seen on imaging, like cochlear nerve dysplasia in the bottom right, or labyrinthine dysplasia in the top left, so any cochlear or labyrinthine changes, or more covert changes right at the microscopic level that we can't generally see, such as genetic protein issues or effects of CNV. And alternatively, examples of conductive hearing loss, as we all know, can generally be seen more readily, right? Whether that's a hole in the eardrum, a retraction, middle ear fluid, or even just the complete absence of the bony ear canal and oral atresia on the left. And now, stepping back a little bit, kind of more of the 30,000-foot view, more broadly, what are all of the etiologies of congenital, conductive, and sensory neural hearing loss? So roughly about 50% of these cases are either acquired or idiopathic, and the other 50% are genetic and etiology generally. And within that acquired category, of course, congenital infections, notably CMV, as we talked about, is the most common culprit, as we previously talked about. And on the right side, within that genetic subset, again, the vast majority of these are non-syndromic cases, of which autosomal recessive is the most common. But about 30% of these are syndromic and can be associated with, of course, other congenital issues which are important to look for. And briefly, before we start kind of diving into the details here, just to kind of emphasize the importance of why we're doing this, bilateral hearing loss, of course, will not only result in lack of listened and spoken language, but also have significant impact socially, emotionally, and on academic employment implications in later life. And so it's obviously important to try to get these kids the services they need. Ultimately, that's kind of the goal of the parents. But what about on the flip side, right? Say if we have one good ear and one bad ear, is unilateral hearing loss still important? Ultimately, the short answer is yes, and there have been a lot of articles really looking at kids with both unilateral conductive hearing loss and unilateral sensory neural hearing loss, including some done by my otology colleague, Dr. Kessler. And in summary, all of these articles have really kind of shown increased rates of grade repetition, resource utilization by kids with unilateral hearing loss. About a third of these kids end up needing to repeat grades, and about 2/3 of these kids ultimately need additional resources just to keep up academically with their peers. And so at the end of the day, really trying to identify and treat these kids is certainly in their best interest. And so now, let's see if the sound works here. Let's see if we can get this transcript to play so we can kind of really try to appreciate the impact of hearing loss.
So you're not going to be able to do this, is that what you're telling me?
I'm telling you, that's probably what I'm going to do. I'm not doing it.
You're just going to sit here and listen?
Yes.
Tell me about work. How was your day?
I don't want to talk about work. The less I talk about work, the better I feel, especially on my day off.
I don't know if you guys can hear that out there. I think it's playing through my laptop here, but obviously a lot of us can empathize certainly with that last statement. But this next one, hopefully you guys can hear it out there, at least to some degree. This is really just now with mild to moderate hearing loss and reflected by the audiogram here. So I know I apologize, the acoustics, it wasn't hooked up here, but ultimately, I mean, you can really tell a pretty significant difference, even just with mild to moderate degrees of hearing loss. And granted, this is a hearing loss specifically kind of in the center of the audiogram, which historically, of course, is the most important for speech production. But still, you can really appreciate how detrimental this could be from speech development, academic progression, and overall quality of life. All right, so now that we have our diagnosis of hearing loss, let's get back to our timeline and let's start our investigatory pathway of these kids. And so ultimately, this starts in the clinic, right? This starts with history, physical exam. Is there a family history of hearing loss? Have they had ear issues? Have they had drainage infections? Are they in the NICU for a while? Do they have any other issues like congenital heart disease, right? Do they go on ECMO? Do they need antibiotics that could potentially be ototoxic? Next, physical exam, of course, is not only critical to look at both the ear and all of that, the kind of related structures otologically, but also the rest of the head and neck. For patients with congenital hearing loss, right, an otologic exam can be anything on the spectrum from completely normal to absence of an ear canal and oral atresia, which you can see on the left. But often for kids with pediatric sensory neural hearing loss, the ear will look totally normal, right? There may be other affiliated or non-affiliated craniofacial abnormalities, sometimes that we can pick on like preauricular pits, whether it's or mandibular or maxillary dysplasia, white forelock, cleft palate, kind of you name it. There are some of these things that we can pick up. And ultimately, history and physical exam not only can help us identify many causes of acquired or syndromic hearing loss, but also potentially highlight future issues and limitations with communication, language development, such as the cleft palate as well. So important to really try to identify those in clinic. But say we kind of go through this, we see the kids in clinic, and we're not really finding anything, right? Kind of a bland history and physical exam. What do we do next? And so as, thinking back to that flow chart that we saw, the majority of these kids are likely to have a non-syndromic genetic source for their hearing loss, of which they may just have a normal history and physical exam, or at least something that stands out. And so this is where the genetics team is extremely helpful in helping us try to identify the etiology of hearing loss. And so a referral to genetics, subsequent testing can really identify any gene mutations which may or may not be implicated in hearing loss. And so for all patients with sensory neural hearing loss of the congenital variety, definitely genetics testing should be a strong consideration, regardless of what we're finding on the history and physical exam. And for those without access to a genetics department, whether out in the community, there are free testing programs such as the Kudos here, which I've kind of highlighted, who offers free testing and consultation afterwards. And so the benefits of course genetic testing are multiple, right? One, it helps us to identify the etiology of hearing loss. Two, of course, if it's a genetic cause, it can help risk stratify the parents if they want to have another kid, or ultimately, of course, the patient themselves later on in life. And then finally, of course, if it's syndromic, it helps to identify other, start investigations of other medical problems that could be going on as well. And then similarly to genetics, ophthalmology should also be highly considered in these kids with congenital sensory neural hearing loss. And so many studies, just one of which I've highlighted here on the right, have demonstrated a high degree of concordance between congenital sensory neural hearing loss and an abnormal eye exam. So this large review by Sharma really demonstrated that over 20% of kids with congenital sensory neural hearing loss had an abnormal eye exam. So not only would it be important to identify those abnormalities, but also to be able to make sure that we are giving these kids kind of, or maximizing all of the senses that they can, right? If they're not going to have good hearing, we want to make sure that their vision is as good as it certainly can be. But again, what if now all of that is negative? We're not finding anything on genetic testing or ophthalmology exam. What is left to eventually look at to, and what's the last piece of the puzzle? And ultimately that can be temporal bone imaging. Both a CT scan and an MRI can both serve important and complementary roles as they evaluate truly different structures along the entire auditory pathway from the ear canal all the way to the auditory cortex. And so CT can help visualize middle ear or inner ear dysplasias you can see here in this top figure, or an enlarged vestibular aqueduct, which I pointed out here. While MRI can evaluate for any cochlear nerve issues like a deficiency or complete absence as well, highlighted here. But these are just a few of the etiologies, of course, of congenital hearing loss that we can find on imaging. And this flow chart here I've kind of highlighted from Merkers was interesting. They did a meta-analysis of all these kids with unilateral sensory neural hearing loss and found that on imaging only identified about 30 to 40% of kids who had abnormalities. And so, of course, while imaging is not perfect, it's certainly not a catch-all. It definitely can be helpful within the context of everything going on here. And so now let's start talking about management. Of course, with a heavy emphasis later on with cochlear implants. And ultimately, we'll be asking the question of today, who should be getting a cochlear implant? So first, broadly, what are our options to try to improve hearing for these kids? Ultimately, it really depends on the type of hearing loss as we discussed earlier. So for conductive loss, we can try to fit a conventional hearing aid. We can discuss surgery. If it's an ear canal, eardrum, vesicular issue, or just completely bypass the system with a bone conduction hearing aid. Of course, for sensorineural hearing loss now, we're a little bit more restricted with either a conventional hearing aid or a cochlear implant for greater degrees of hearing loss than what a hearing aid can amplify. And so regardless of classification and degree of hearing loss, as long as the patient has a patent ear canal that is suitable for a hearing aid, this really should be kind of the first step, and it's never the wrong start. And so a return trip to audiology will, of course, help facilitate amplification, which even in the case of profound sensorineural hearing loss bilaterally, also effectively starts kind of the formal cochlear implant evaluation process. And so now for the rest of the talk, we'll be focusing on sensorineural hearing loss and cochlear implants. And so briefly, I'll just mention this here, which I'm sure many of you all know very well, but a cochlear implant, of course, is a small device that we are surgically implanting that attempts to restore hearing. So it has two parts, one of which is underneath the scalp, and then the other part that actually, the part that's underneath the scalp ultimately communicates with the external environment, the external processor that has a microphone, and then the other part is the electrode that physically goes inside of the cochlea to electrically stimulate the hearing nerve. Of course, I'm biased, but I do think it's probably one of the greatest bioprosthetic devices probably created at least yet to date. It's pretty amazing. And so to answer our first question of really who should be getting a cochlear implant, this kind of needs to be answered from two different ends. So one, of course, are they an audiologic candidate? And then two, are they a medical candidate? So first, I think it's best to think about the audiologic candidacy from where we're at from a cochlear implant audiology perspective is kind of really best framed in this historical context of cochlear implants, which I think is fascinating in of itself. So cochlear implants were first approved in 1985 in adults, but not until 1990 in children. This has then been progressed over the years, as you can see here in this table, and improvements over the years have included lowering the age range, age limit required for a cochlear implant, implanting with residual hearing, easing on speech requirements, and now even implanting some of these kids with single-sided deafness, so one good ear and one bad ear. And finally, while these are, of course, the FDA limits and criteria, there's also insurance criteria and limits that need to be followed so we can get this device paid for. And usually, of course, these are in line with the FDA, but sometimes they can vary. And so I think one of the more notable ones to highlight is about a year or so ago by United Healthcare. They actually recently approved cochlear implants for kids down to 6 months as opposed to 9 months that the FDA outlined. And then for single-sided deafness, actually a pretty remarkable decrement. They brought that age range down to 9 months as opposed to 5 years. And so it's really cool to kind of see this envelope being pushed from the insurance agencies. But that is just one part of the puzzle, right? That is the audiologic understanding. And now we have to really kind of understand, does that mean they're a good medical or an otologic candidate for a cochlear implant? Because these two are definitely not always congruent with each other. So there are very few absolute contraindications for a cochlear implant, as you can see here, which really boil down to the two elements we need for a cochlear implant to work, right? We need to be able to have a structure to be able to put this electrode in, and then ultimately a nerve or some conduit to send these signals from the ear to the brain. And as long as there's some remnant of those structures, theoretically, an implant can be placed, but of course, caution should still be taken in many of these situations. And a lot of those are kind of what I've termed these relative contraindications that I've kind of listed here on the right. And so many folks in these categories on the right can still have good outcomes. We just need to make sure we're kind of prepping patients and parents for expectations after surgery, because they certainly can be significantly variable than somebody who may have completely normal anatomy or no other concerns from a medical perspective. And so now that we know somebody is a candidate, let's start kind of making a game plan for surgery. So this now asks, when do we do the surgery, where or which ears, and then ultimately are we doing one ear or are we doing both ears? So let's first start with the question of when. And so when we're talking about hearing loss in children, I know I'm preaching to the choir here in this rate, but it's very important, of course, that we distinguish when the deafness or when the hearing loss occurred. Was it before or after language development? And so if hearing loss, of course, occurred before language development, then we're going to term this prelingual deafness. And if it's after, we're going to term this postlingual deafness. And this is incredibly important, as not only it determines the timing of implantation, but also possible candidacy for implantation in general at all. And so let's start with the postlingual deafness question of when, because it's a little bit clearer to answer. And so within this context of implanting these kids postlingually, the main question is really, does it matter when we are putting in the implant if they have already developed language? And the historical thought and answer to this is yes, and a meta-analysis by Bernhardt here on the left clearly showed a negative correlation between word and sentence scores, so ultimate speech outcomes with cochlear implant, with increasing duration of deafness. However, more recent studies, one of which I've highlighted here on the right, have really put this into context of other confounders, such as daily processor use really being the most important one, and found that when controlling for daily device use, so how much they're actually using their implant, any impact from duration of deafness on speech outcomes ultimately became obsolete. And so this figure here really shows the amount of variance in speech outcomes determined by daily processor use age of implantation, and duration of deafness. And you can see there's pretty minimal variance explained by duration of deafness or age, and a significant amount by how much they actually use the processor and the implant. And we'll discuss this a little bit more later on as well, but this is just incredibly important. And so the takeaway here is that if language is already developed by the time of hearing loss, timing of cochlear implant in these kids is probably less important than we historically thought. But now, on the flip side, let's talk about most of our kids, which are, of course, prelingual deafness, such as these kids, they were born with deafness and profound hearing loss on both sides. When do we ultimately proceed with surgery for this cohort? And so a lot of studies have evaluated the optimal timing of kids with congenital hearing loss and consistently found that implantation prior to 2 years old is key. After 2 years old, the implant outcomes generally start to fall off. And so this graph here on the left is from one of those papers. They plotted speech perception outcomes for those with cochlear implants that were either implanted before or after 2 years old. And as you can see, those implanted generally before 2 years of age had better outcomes regardless of how long they actually have the implant. More recently, this envelope has actually even been pushed even greater and found that even implanting before 2 years old, even before one, may even provide better outcomes. And so this figure up here on the top right is a study by Hoff et al. And they generally found higher rates of open set and exclusive oral communication among those who were implanted before 1 year old compared to those that were implanted here between 12 and 24 and ultimately greater than 24 months. As you can see, as the age group increased, rates of receptive and expressive language significantly decreased. And then finally, and even outside of language acquisition, Chen et al. Recently found that infants implanted under the age of 1 year had better adaptability, social skills than their peers who were implanted after 12 months. And so overall, the earlier the better probably for implantation, though maybe this first 2 years old is probably a critical window for us to shoot for. But now, what about on the other end for these kids with prelingual deafness? Is there such a thing as too late of an implant for these kids? And the short answer and the decisive answer is definitely yes. So we need to make sure ultimately that the implant is done before there's been cortical remapping and ultimately the brain just permanently shuts off the auditory cortex. And so this first image here on the left from Sharma et al., they actually evaluated the latency of these automated evoked potentials, so like an AVR, in prelingually implanted kids, and found that if an implant was done prior to 3.5 years old, then nearly every time the evoked latency was pretty similar to their normal peers. However, on the opposite end of things, if they were done after 7 years old, then there's almost never normal outcomes and normal latency for these kids. And between those, it was kind of a toss-up. And so the authors suggest that probably maybe 7 years old is kind of the absolute endpoint before cortical remapping takes place. A more recent study here on the right, which really looked at behavioral outcomes in these late implanted prelingually deafened patients, by Pediatric et al., demonstrated that in these prelingually deafened kids who were implanted after the age of 5, sentence scores, word scores generally started to show pretty significant decrements compared to what we'd expect for otherwise normal kids, averaging kind of in the 30s and 40s, which you can see here, which, as we'll review later, is significantly worse than what we would hope for in these kids. So really putting this all together, it's probably clear that there's a possibility of having some degree of improvement until the age of 7, though this generally significantly starts to drop off after the age of 5, such that really serious consideration for foregoing implantation should be given kind of at that age. Ideally, before 2 is great, and maybe even before 1 could be optimal. This, I think, still is needing to be parsed out to some degree. And so now that we've answered the who and the when question, we need to ask kind of this where and why. So for where, the next decision point is, do we implant one or both ears, assuming that we have bilateral hearing loss? And really to answer this where question, we have to answer why. So this then posits the question of binaural advantage, or what is even the benefit of having 2 ears as opposed to having 1 ear? The binaural advantage not only facilitates listening in complex environments, such as those with background noise. In those situations, we ultimately want to increase our SNR, what we call our signal to noise ratio, by increasing our signal, decreasing our noise, and at the end of the day, knowing where this sound is coming from to ultimately allow us to hear better in these complex environments. And this is generally accomplished only in the binaural setting in 4 different ways: summation, head shadow, squelch, and localization. And broadly speaking, without getting into the weeds too much here, summation generally tends to increase the signal of sound, whereas head shadow and squelch are both the physical and neurologic alterations respectively done to decrease the noise that we hear. And finally, localization, of course, helps us to be able to move around to really optimize these effects. And so in essence, all of these serve to increase the signal-to-noise ratio, providing that binaural advantage and better hearing with 2 ears as opposed to 1. And as such, it's probably not surprising to any of us to find that language outcomes are better with bilateral implants as opposed to unilateral peers. So this top figure here from Eskridge et al. Evaluated kids with bilateral hearing loss who either got 1 or 2 cochlear implants, and they showed higher receptive and expressive language scores in the bilateral cohort compared to only those who had 1 implant. And then more granularly here in the bottom figure, this is by Sarant et al., and they demonstrated a higher receptive language scores in multiple different test conditions, which they've kind of outlined here in these different testing paradigms for those with 2 implants compared to those with just 1 implant. And so now that we kind of have at least some data to support the concept that 2 implants may be better than 1 implant, we need to know, are we going to do both these at the same time, like are we going to try to do 1 surgery simultaneously, or are we going to do them sequentially at 2 different time points? And a great study by Gordon back in 2009 thoroughly evaluated these kids who either underwent simultaneous or sequential bilateral implantation with varying degrees of time interval between implants if they were in that sequential cohort. And the image on the left here ultimately demonstrates the improved speech scores for those undergoing simultaneous or short delayed sequential surgery compared to those who had a long interval between the 2 cochlear implants. They then quantified this in a little bit more of a granular way here on the right side, I think, which is awesome. And they ultimately tried to ask the question of what was the gained benefit of that second implant plotted along essentially, or versus how long that time interval was between those 2 implants, and ultimately found that for those with shorter delays between surgeries, ultimately had more benefit from that second cochlear implant independently. And then finally here, just another study looking at simultaneous surgery, found it's safe, it's practical, reduced OR time, really a node without any difference in adverse outcomes for these kids compared to staged surgery. And so now that we have our game plan, right, we know we may want to do 2 ears, may want to do them at the same time if possible. How are we actually going to execute this? So this now asks kind of the intraoperative questions of how exactly we're going to do it and what exactly we're going to do. And so one decision we need to make before surgery is what electrode to use. So this gets a little bit into the weeds here a little bit, but I promise I'll try to keep it brief here. So let's consider this within kind of an anatomic context, both for normal and abnormal anatomy. So within normal anatomy, broadly speaking, there are 2 different types of cochlear implant electrodes. There is one that are straight and ones that are pre-curved. They're kind of pre-curved and meant to kind of hug the inside of the cochlea, which you can kind of see on the bottom right. And these straight electrodes are generally considered less traumatic during insertion, maybe facilitating better hearing outcomes or hearing preservation, notably after surgery, while pre-curved electrodes, because they kind of hug the inside of the cochlea where the nerve endings are, may ultimately have better hearing outcomes in the long term. And that's kind of what we've come to learn over the years, and this is a recent meta-analysis generally demonstrating that. So they ultimately found there's probably slightly better speech outcomes with these pre-curved electrodes as opposed to these straight electrodes on really long-term follow-up. However, some surgeons, still prefer straight electrodes because they can be longer, they can cover more of the cochlea itself, and because the cochlea has this tonotopically based organization, so frequency dependent on the exact location within the cochlea, higher frequencies at the base, lower frequencies at the apex, you're generally allowed to cover more of that potentially with a straight electrode as opposed to a pre-curved electrode. And sometimes even best accomplishes, some centers are using planning software with CT data to really determine the exact length of the cochlea. You kind of unfurl that snail shell to see how long it was to get the exact length of it to be able to help kind of really get the best place to pitch match between the implant and the tonotopic organization of that specific cochlea. But I think at the end of the day, regardless of which one we're doing, the ultimate goal of the surgery is to get a full length and atraumatic insertion of the cochlear implant electrode. And so how do we do it? In the vast majority of cases, we're going to proceed normally without any alterations, kind of like this video that I'll just let play. We expose the mastoid through an incision behind the ear. We drill that mastoid. We find the facial nerve, we find the area in front of the facial nerve, ultimately exposing the middle ear where we're going to be able to identify the cochlea, and then we ultimately place the cochlear implant through the round window. However, there are definitely specific considerations, which we touched on a little bit earlier, where we're going to have to adjust or we're going to have to change gears in the operating room depending on exactly what we see. So we'll consider this first as how anatomy may complicate this, but then also how specific disease states can ultimately complicate an otherwise normal cochlear implant process. And so when there are inner ear malformations, so when there is any sort of kind of dysplasia of the cochlea or the labyrinth, there's always a risk of having any facial nerve malformations that may kind of run in a different course than its normal expected course. And as we just saw, standard implant surgery is very dependent on the location of that facial nerve. And so a different course of the facial nerve can, of course, make us needing to change our pattern or our specific approach to getting the cochlear implant in. And so here's a good example of this. This is a kid with Charge syndrome. It is very common for kids with Charge to have inner ear malformations when they come to see us. And because of that, having a abnormal course of the facial nerve can be pretty common. And in this specific case, it was kind of coursing directly over the cochlea. And so we had to kind of make a different approach going through the ear canal itself, needed to remove the ear canal, close off the ear canal laterally to be able to safely put this in. And so anytime that the anatomy is not safe, and we need to make sure that we're doing what we can to effectively get the electrode array in while decreasing morbidity, this can potentially be utilized. But what about another aspect where anatomy can really complicate this? This can also be seen in cases of inner malformations where there could be a direct connection between the cochlea and the subarachnoid space if there's a lack of this bony partition between the two. Okay? I've kind of outlined just a representative CT scan here in the top left where you can see there's really no bone separating the cochlea from the internal auditory canal. And so as we open up the cochlea for implantation, this was an IP3 case, so a specific type of cochlear dysplasia, we really get a vigorous spinal fluid leak coming out of the cochlea. Of course, we need to stop this before we can kind of close up and turn on the cochlear implant, and so there are a number of ways we can do that, including packing around the round window. We can obliterate the ear, we can close off the ear, or do a lumbar drain. So there are kind of a few things that we have at our disposal, but of course, just another important thing to make sure that we're preparing for before surgery. And then finally here, a few disease states which can complicate things. One of which I think is really poignant for this talk specifically is labyrinthitis ossification. So we briefly touched on this earlier, but because there is this natural connection between the cochlea and the subarachnoid space, even if there's no degree of dysplasia of the hearing organ, there is always a risk of having any cochlear inflammation after meningitis, ultimately leading to fibrosis, inflammation, and possible new bone formation within the cochlea. And if this has happened by the time of implantation, ultimately we may need to drill out the cochlea and try to drill out, remove that bone within inside of the cochlea in order to be able to actually find an opening or a lumen within the cochlea to be able to get the electrode in, because that's obviously what we're trying to accomplish here at the end of the day. And so this is kind of just a few representative images, and then this is from a more recent case where as a kid had bacterial meningitis, ultimately recovered well from that, but had ongoing progressive ossification with inside of the cochlea, so we had to drill that out before trying to identify a lumen to be able to put the implant array in. And then just here, the last disease state, which I'll talk about just because it's a little bit more common, of course, thankfully, than meningitis, is chronic ear disease. So this, of course, encompasses this full spectrum of having an eardrum perforation, eardrum retraction, osteotoma, draining ear, kind of you name it. We ultimately want to avoid putting an implant in one of those settings, right? We don't want any degree of otorrhea or any degree of skin to be able to come in contact with the electrode array, because this could ultimately cause many issues later on down the line. And so in general, our options here are kind of twofold. So one is to kind of fix the underlying problem and then come back in a staged fashion, put in the cochlear implant, or alternatively do everything in one stage, like we talked about earlier, where we actually remove the ear canal, we remove the offending disease, and place the implant at that same time. And a representative postoperative picture is kind of seen here on the right, where we're saying not much external change in the auricle or the ear itself, just of course an absence of the ear canal. Much of this kind of choice between these two approaches can be left up to the patient. But one study we did, kind of looking at quality of life between patients who kind of underwent both of these, really noted no significant change between the two. So if people want to have one surgery, maybe they're older, they're sicker, we just need to have kind of one degree of anesthesia, then we can go ahead and do them. That could be a good option for those patients. So now after the implant is in, what do we actually expect for these kids long term? So for bilateral sensorineural hearing loss as a whole, this recent study demonstrated really significant improvements and great outcomes in multiple different testing paradigms post-operatively. They further stratified these by when kids were implanted before or after 1 year of age. And overall, their speech scoring is great, right? We're seeing kind of in the 80 to 90% range, which is really amazing for these kids. And again, this is in kind of the bilateral hearing loss setting, whereas on the contrary, if we're looking in the unilateral hearing loss setting, this meta-analysis on the right, again, demonstrated significant improvements in the SSQ score, which is a questionnaire, validated questionnaire for hearing loss, and they compared it to kind of the preoperative status. They noted that speech hearing, spatial hearing, and hearing quality were all significantly better after surgery compared to before surgery. And so overall, we have pretty high expectations for these kids with normal anatomy in both the unilateral and bilateral hearing loss setting. But what about when anatomy is not in our favor, like we talked about earlier? For the sake of time, I won't go into all the details here, but generally for both congenital or acquired anatomic issues within the cochlea or the hearing nerve, they generally lead to poor hearing outcomes post-operatively. So it gives us a little bit of hesitation and maybe one of these kind of relative contraindications that we talked about earlier if the potential benefits of cochlear implantation really don't outweigh the risks. And so really just making sure that we are counseling these patients effectively with the appropriate expectation to know if this is the potentially right choice for their child. But what else gives us pause? I'll take a little bit of time here to discuss CMV, just given its prevalence. And so a relatively recent systematic review evaluated both symptomatic and asymptomatic CMV cases and compared them to normal non-CMV controls. In essence, they found that asymptomatic CMV cases had no difference compared to their normal controls without CMV. But those with symptomatic CMV did have a notable difference compared to those without CMV. And then these symptomatic cases included primarily kids with cognitive delay, motor delay, and behavioral difficulties. And then further here on the right, they ultimately compared symptomatic to asymptomatic CMV outcomes and noted a significant difference even here, as you can see on the right, with asymptomatic children doing better than symptomatic children. And so ultimately, these findings together probably demonstrating that it's really not the virus itself that's causing the poor speech and language outcomes after cochlear implantation, but the comorbidities that are likely associated and predictive of worse outcomes. But even in the cases of normal anatomy and normal central processing without CMV, we can still see significant variability in cochlear implant outcomes, which can be also predicted by some postoperative factors like we talked about earlier. Really, the main one is wear time. So it's long been known that the amount of time somebody's wearing their implant, the better the outcomes. So it's just like anything else, right? The more that we're practicing, the more that we're going to the gym or whatever it is, right? We're going to do better with all of that. This has been verified in both the adult and pediatric populations. So for instance, the top figure is by Lindquist et al., demonstrating that the amount of time that somebody is wearing the device at 1 month after activation, so after we were turning on the implant, was predictive of word scores both at 1, 3, 6, and 12 months post-operatively or post-activation. And then Globitz et al. On the bottom figure here evaluated bilaterally implanted pediatric users and also noted a strong association between wear time and exposure to speech with ultimate word production. So in short, the more hours of wear time, the better the speech outcomes for these children. And likely some of the drivers behind wear time are social determinants of health as well, which are super important. So a great paper just published earlier this year by Mueller et al., they demonstrated a significant correlation between expressive language scores after cochlear implantation with parental education and socioeconomic status. And so the higher the level of parental education and socioeconomic status they found, potentially the better the speech outcomes were. So while age of implantation is definitely important, as we mentioned earlier, interventions aimed at the child's home, school environment may be of equal importance as well. So I know we're running short on time here, but I'll start to kind of wrap things up by really focusing on kind of the next frontier of cochlear implant research, in my opinion, which is quality of life. So the majority of literature that we previously looked at here really focuses on speech outcomes, like how many words are they actually getting right, of course, when they're wearing their implant. And this is all great, but how does this actually correlate to quality of life? Because that is what's ultimately more important to us at the end of the day. So a great study a few years back from Sejas et al. Compared long-term quality of life and academic outcomes in cochlear implant users compared to those who had similar hearing but without cochlear implants. And then they also compared both of those cohorts to their normal hearing peers. And so the figure here on the left compares the NLTS as kind of those blue squares. And these are the peers who had severe to profound sensorineural hearing loss but who did not have cochlear implants compared to children with implants who are either implanted before or after 18 years of age, or 18 months of life, I apologize. They demonstrated notably better academic outcomes in language, math, and reading with cochlear implant compared to those who did not ultimately have a cochlear implant. And furthermore, those even implanted prior to 18 months tended to have better outcomes than those implanted after 18 months, as we previously saw earlier. And similarly here, this graph now on the right evaluates multiple quality of life domains. Overall, it demonstrated better quality of life for those kids with implants compared to those who had similar hearing without cochlear implants, as denoted kind of by the referenced studies, and then also demonstrated similar quality of life to those with cochlear implants compared to normal hearing peers, which is honestly just absolutely amazing to me. And so at the end of the day, are there any other modifiable drivers of quality of life that we can do and enact to ultimately help these kids, be satisfied with their cochlear implant? And so this is from the adult literature, not the pediatric literature, but I'll highlight it here because I think it's really amazing. It was a fascinating study done a few years ago out of NUSC. They demonstrated that preoperative expectations are similarly important to satisfaction and ultimately decisional regret. So did these people actually regret their decision of undergoing a cochlear implant? They had experienced adult CI users fill out this CI quality of life data sheet and then ultimately asked about satisfaction and if they regret their decision to undergo cochlear implant. Individual data here is plotted on the left with the red bars demonstrating low satisfaction or decisional regret, and generally those with worse communication skills and worse word recognition, seen in the bottom two rows, had more regret and low satisfaction, which makes sense to us, right? If you're not hearing well with your implant, you're not going to be super satisfied, and that makes a lot of sense. But more consistently associated actually with regret and low satisfaction were those who actually had worse outcomes compared to their preoperative expectations, which is noted in the top row. This is probably better demonstrated graphically in the bar graph on the right, which shows low rates of regret, those who had better alignment between their preoperative expectations and their postoperative outcomes. And so my wife teases me a little bit about this because I probably talk about it too much, but I'll posit the question to you all to some degree. Are low expectations the key to happiness? Probably not for everything, but at least maybe in the cochlear implant world they are to some degree. So that's all I have here. Here are a few conclusions. Ultimately, it's really important for all of us to be working together from audiology, pediatricians, otolaryngologists to be able to kind of have this multidisciplinary team to help identify these kids, help them not slip through the cracks, and ultimately achieve the targets that were set out for us from the federal government. Obviously, unilateral, bilateral hearing loss can have detrimental effects not only on quality of life, but ultimately development. It's important to be able to understand both the audiologic, the medical candidacies for kids with cochlear implants, and really the timing of all of that is extremely important, so that who, what, when, where, why, and how are really all questions that need to be answered before we undergo surgery. That's ultimately what the family decides to do. Speech outcomes, quality of life after implantation are generally great, but again, they can be very variable, and there are a lot of things that ultimately go into that, such as data logging, device usage, social determinants of health, and preoperative expectations are all really integral to success and satisfaction in the long term. And then I just thank you all for having me here. This is my email, please reach out. Here's some references, and this is the great team that I get to work with, similarly to the great team that you guys have here, otolaryngology, audiology as well, to really help take care of these complex kids. So those are happy to take any questions.
Question. Can you talk a little bit more about the technical aspects of the device? Like, what is the electrode made out of? Can you develop an allergy? How long does it last?
Yeah, it's a great question. So it is generally wrapped in some degree of a silicone base, and so very rarely, but sometimes we'll come across folks that have what we presume are kind of allergic reactions to the implant itself, and they'll kind of have this situation where they present with kind of cyclical asymptomatic swelling around kind of the receiver stimulator up here. So maybe a little bit painful, but generally they feel fine, but you see them and there's just kind of a little bit more edema than we would expect over the implant. And so we think that may be related to kind of an allergy to kind of the casing of the cochlear implant. And so sometimes if we suspect that, we can exchange it for one that does not have that type of coating. And thankfully that's pretty rare, but it does happen. And then the life expectancy of these we expect them to be there for the rest of their life. And so
because you wouldn't be able to take it out, right? I mean, once it's in there and tissue is formed around it,
Yeah,
You can't exchange it.
yeah, we definitely don't want to. There are definitely times where we have to, and each manufacturer, there are ultimately 3 manufacturers that make implants, and each manufacturer has kind of gone through their period of, pain where they've had to maybe kind of recall some devices for one thing or another, and so we've had to go in there, take out an electrode array and put in another one. Thankfully, it is uncommon that these fail, but sometimes they can just because they're man-made devices and things happen.
And does the external attach, like with a how does that attach to?
Yeah, via magnet back here. Yeah, so some people, generally non-kids of course, but older adults, if they have kind of thicker soft tissue, sometimes even getting magnet adherence can sometimes be a problem, but we have different strength magnets. Sometimes we'll have to kind of even decrease the thickness of the scalp in order to kind of get the good adherence via a magnet. But everything is underneath the skin, so if they just take the device off, otherwise nobody knows they have it, and they go to sleep, they take it off, they charge the battery, they wake up in the morning, put it on, and they're ready to go.
So for kids babies coming out of the newborn nursery or NICU with a failed hearing screen, trying to get urine CMV sometimes can be a difficulty, and if we don't have the ability to do buccal swabs, do you recommend that we send it absolutely on all kids before leaving the hospital?
Ideally, yeah, really hitting that kind of 21 days of life is really important, because if we get a result after that, it's generally not that helpful in kind of knowing if that was what was going on, just because it could have been kind of a postnatal acquired infection, which really doesn't carry the same risk of hearing loss as we all know. And so, of course we can always send off antibodies, and if there are no antibodies, then maybe that makes us feel better, right, that there was never an infection at all. But if they're positive, it doesn't really tell us kind of when that infection occurred. So definitely, I completely agree. Sometimes it is hard to kind of get that, whether it's a buccal swab or urine is a positive.
They put a urine bag on for 10 hours and just don't go or go around it. Yeah.
I think there's some research looking into like the blood spot, actually using that to some degree as well.
Questions? Thank you, Dr. Lovin.
Yeah.